So welcome everyone. We're going to go ahead and get started. Excuse me. Thank you for joining tonight's Smart Round. We have Dr. David Netscher on with us tonight. He is an academician with a lifelong career at Baylor College of Medicine in Houston. He has served as professor in the Department of Orthopedic Surgery and Division of Plastic Surgery since 2006. And is the program director for the Hand Surgery Fellowship for more than 20 years. His specialty involves congenital anomalies, trauma, arthritis, contractures, oncology, vascular, and peripheral nerve problems. Additionally, Dr. Netscher has served as the director of both the American Board of Surgery and the American Board of Plastic Surgery, as well as the Conjoint Hand Surgery Board. So, Dr. Netscher, I will turn it over to you if you want to go ahead and share your screen. We'll get started.
Good evening, and thank you very much for that introduction. And thank you too for everyone for joining us again after our false start last week. And I apologize for being such a electronic, maybe I'll just leave it at that. So today we're going to talk about part one, sports medicine, hand and upper extremity. And our topics for discussion are going to be, by request actually, was distal radius fracture, scaphoid fracture, and then going on with that scapholunate ligament injuries, which you really can't separate from scaphoid fractures. And then the thumb metacarpal ulnocollateral ligament injuries, and then lateral epicondylitis. I'll just have a segue for part two, which will be next month, when we'll cover metacarpal and phalangeal fractures, which are very commonly injured in the sports arena, as well as closed tendon injuries, such as boutonniere and mallet deformities. And then we'll do the various more common tendinitises and tendinopathies with the next presentation. So first of all, we'll talk about distal radius fractures and management. And up front, we need to be good doctors. We need to be good physicians. We need to take a history. Are there associated injuries that might be more important? For example, a crunch on the football field might be associated with a neck injury. So don't just focus on the fracture. Have there been any prior injuries or surgeries? Comorbidities, generally athletes are healthy, but some of them, of course, may have diabetes and other medical issues. But now, particularly when we evaluate the extremity itself, associated symptoms, and the most important is looking for potential nerve entrapments and nerve injuries, and so that involves pain and paresthesias. So the gross inspection is, first of all, we look at the deformity, and we can almost tell by looking at the deformity what the X-ray is going to look like. How much associated bruising, is the skin intact or not? Because clearly an open fracture needs much more urgent intervention and operative management. We need to look at the part distal to the fracture, particularly the vascular exam and good perfusion. But the neurologic examination is particularly important, and especially in the median nerve distribution. We'll look at 2-point sensory discrimination at the fingertips of the median innervated digits, so in other words, the thumb, index, and middle finger. And some initial paresthesias in this distribution are actually quite normal. That doesn't mean they have an acute carpal tunnel syndrome. But if the initial exam is very profound, with dense hyperesthesias and muscle weakness, particularly with thumb palmar abduction, so that's lifting the thumb away from the palm, or if there are progressive symptoms that are getting worse and worse, then that also warrants early intervention, because we'd want to do a carpal tunnel release in association with potentially the fracture resolution, to avoid permanent nerve injury. And then, of course, if there's a clinical suspicion of compartment syndrome, this may require urgent surgical decompression. The radiographic examination, characteristically, the three views, the PA, lateral, and oblique of the wrist. And, of course, the lateral is the giveaway, the classic so-called dinner fork injury, as the colleagues described it. When you land on an extended wrist, the fracture gets pushed backwards, and so you get then that dinner fork deformity. It's important to understand normal and abnormal radiographic parameters. The first is the radial inclination, so that's the slope of the distal end of the radius, and that has a normal average of 23 degrees, followed then by the radial height, which is the vertical distance between the radial styloid and the ulnar edge of the radius, which is 12 millimeters. In turn, followed by the volar tilt, and this is very important to assess because the tilt of the radius is usually facing forwards and not backwards, as is in this case. And that is normally inclined forwards at 12 degrees. In this particular X-ray, it's inclined at -13 facing backwards. And finally, looking at the fragments that might be intra-articular, and if there's a step-off of more than 2 millimeters, then that sets you up for future arthritis, and this is almost then a certain need for fixation and manipulation of those fracture fragments. Or the fracture may be settled, and so the ulna becomes so-called positive and has a positive variance, so it stands higher than the radius, in which case you're going to get a protrusion of the ulna onto the carpal bones. So we're looking at the joint surface and the ulnar variance. So the management goal is to restore normal parameters as closely as possible. So it's important to recognize those abnormal X-ray parameters, and that in turn will improve functional outcomes. So clearly abnormal, and after a successful closed reduction and splinting in the emergency room, it can provide relief and potentially obviate the need for surgery. What do we need if we're going to do a closed reduction in the emergency room? Well, obviously local anesthetic, and we do a local anesthetic injection into the fracture site, which is called a hematoma block. The patient is on a stretcher in the supine position. The arm is abducted and 90-90, so 90 degrees at the shoulder, 90 degrees at the elbow. The index and middle finger are placed in finger traps, or sometimes the index finger and the thumb, it doesn't really matter, and hanging from an IV pole, and in turn placing 10 pounds of traction on the hand and the arm. And the fracture often will just reduce itself when left hanging. If needed, closed manipulation and reduction implies then pressure, either dorsal or volar, depending on the distal fragment, whichever way it's pointing, to push the distal fragment into alignment. And then placement of a sugar tong splint while the arm is still in traction and molded to stabilize the fracture. Why a sugar tong splint? Because it controls the forearm pronation and supination, so you don't get that twisting effect on the fracture site. So it's not only a splint across the wrist or a cast across the wrist, but a sugar tong splint that controls the elbow and forearm pronation. So the supplies for a successful reduction, you need a 10 cc syringe and your hypodermic needle, finger traps, IV pole, and 10 pounds of weight. And you can even use IV fluid bags if you need to. Then you need your splint supplies, web roll, rolls of plaster and bias, and ace bandages. So the hematoma block, you insert the hypodermic needle and syringe directly into the fracture site. If it's an acute fracture, you know that you're there because when you withdraw, you'll have blood in your syringe. and then you inject 10 cc's of local anesthetic right into the fracture site. This is a video that I'm going to share with you, and it's really nice. It shows in cartoon form how this is all done.
Distal radius fractures are commonly displaced or angulated. If they are allowed to heal in such a position, it may result in deformity and partial loss of function. Pulling the fragments back into alignment is commonly referred to as setting the bone. The procedure is more technically known as a reduction. A closed reduction is when the fracture is reduced without making an incision and exposing the broken bone. The distal radius is generally considered to be well aligned based on certain parameters measured with X-rays. If the fragment is tilted too far forward, it is known as volar angulation. If it is tilted too far backward, it is known as dorsal angulation, which is very common. If it is tilted too far to the side, there may be loss of radial inclination. Sometimes the fracture is shortened, resulting in shortening of the arm. Sometimes the fracture is displaced enough that the bone does not have a chance to heal correctly. If there is displacement or step off along the joint surface, it may result in early wear and tear in the joint, which will cause arthritis and chronic pain. In these situations, a reduction should be performed. A closed reduction is painful, and some form of anesthesia should be provided. This may be done with sedation. It may also be done with a hematoma block. This is when a local anesthetic, such as lidocaine, is injected directly into the fracture hematoma, numbing the painful area. Sometimes the wrist will not relax enough to perform the reduction, even when the patient is sedated. If this is the case, sustained traction across the fracture site may help to fatigue the muscles and the wrist will relax. The reduction itself is performed by pulling the wrist in traction. Force is then applied to push the fragment back into place. It is often necessary to accentuate the fracture while applying traction to free the fragment before pushing it into place. Once the fracture is well aligned, a cast or splint must be applied to hold it in alignment. A sugar tong splint is a popular choice because it can be molded to hold the fracture in alignment, prevents pronation and supination of the forearm, and allows for swelling. The cast or splint is applied using 3-point molding. One hand is applied at the fracture site, another distal to the fracture site on the opposite side of the wrist, and an assistant's hand is applied at the elbow. This molds the cast or splint in such a way as to prevent the fracture from moving back out of alignment. When the cast or splint has been applied, X-rays should be obtained to confirm that the fracture is well aligned.
So going on then, that would be the post-reduction maneuver, and we've now got a well-aligned fracture. And in healthy young people, that may be all that is required. Surgical fixation is also used to restore and maintain the normal anatomy, and it's done at surgeon discretion. Now, in a growing skeleton, an immature skeleton, so a teenager who's perhaps an elite ball player, you don't want to go putting plates and screws across a growth center. So we'll rely more on closed manipulation and perhaps simple Kirschner wires across if the fracture seems unstable. But in an adult, we'd certainly be more prone to use plate and screws, and it involves an open surgical reduction and then on plate and screws at the volar wrist. It can all be done under regional block. The patient doesn't have to be put under general anesthesia. Of course, in young, healthy people, it doesn't matter too much, but these are also fractures that occur in the elderly, and so they may be reluctant to have a general anesthetic. And so we can then use a brachial plexus block, and ultrasound guidance has certainly helped with the precision of the brachial plexus block. And you can see here is the trajectory of the needle. Here's the nerves in the brachial plexus sheath with the vascular structures, and then shown in cartoon form, again, the needle coming in from the side, the brachial plexus sheath right adjacent to the subclavian or brachial artery. So regional blocks reduce the risks of anesthesia, particularly in older patients. And then postoperative splinting is important. So we'll now go on to scaphoid fractures, and scaphos is the Greek word for boat, and that's the shape of the scaphoid bone. It is the most commonly fractured carpal bone in the wrist. We tend to lean more liberally towards operative fixation, especially in the elite athlete, even for the non-displaced scaphoid fracture. But in spite of our vigilance, we probably miss a number of these patients with scaphoid fractures, and they simply shrug it off as a sprained wrist because many present later with non-unions, when in fact it's a little bit too late and you have a much more complicated scenario. The scaphoid bone is very difficult to heal because 80% of it is covered by synovium and has a very poor vascular supply. The scaphoid bone is also very mobile, and if you hold your wrist up like this and you can see the prominence of the scaphoid bone, as you go from radial to ulnar deviation, that bone flips into flexion and extension, so it's constantly moving backwards and forwards, and it also has a very poor and limited blood supply. It articulates with many bones, proximally with the radius and with the lunate and the capitate, and distally with the trapezium and the trapezoid. So the history is again similar to a radius fracture where you fall on an outstretched hand. Patients will report weakness. Often they may present a little bit later because they don't remember the exact injury. However, if it happens on the field, as for example, a baseball player sliding into base, the rules of baseball really generally have you take that patient out of play right away. The other sports tend to be a little more liberal, and they may carry on playing or pad up the wrist and finish the game, unbeknown as to what damage is occurring to the wrist. Examination is swelling in the anatomic snuff box. So in this area here, range of motion, wrist flexion extension may be uncomfortable and reduced. There's tenderness in the snuff box, but more particularly tenderness again over that distal pole of the scaphoid. So not only in the snuff box, but over the distal scaphoid. And that may be more specific than the snuff box tenderness that's always quoted in textbooks. Radiographs are important. Normally said we of course have PA, lateral and oblique X-rays, but if you're suspecting a scaphoid fracture, you need one additional view, which is the ulnar deviated view. So you take the wrist it's a PA, ulnar deviating towards the little finger, because that then expands the scaphoid and you see a good elongated view of the scaphoid. Another view is a clenched fist view, so you can see this patient is grasping around a cylinder, because that may show you a ligament injury where you get widening in this gap between the scaphoid and the lunate bones. And then you'll compare right and left sides, and you can see there's a difference between the two and a suspicion then for a ligamentous injury. And then looking at Galula's lines, it's really just an eyeball that those are all in line. Galula was a radiologist who had a great interest in musculoskeletal radiology at St. Louis at WashU University, and then the lines in the mid-carpal joint as well to see that those are all nicely lined up. Advanced imaging may be necessary. either with CT or MRI, it's particularly important when you have your sagittal views to ask for views directly along the long axis of the thumb metacarpal, because it's only with that view will you get then the long axis of the scaphoid. A straight sagittal view will actually give you cuts across the scaphoid, and so you won't visualize it very well. An MRI, additionally, this of course is a CT scan, an MRI will give you soft tissue views as well as and help you determine potential ligamentous injuries. So this is the correct way then to take a scaphoid view, the sagittal view, along the axis of the first metacarpal, and you need to ask them to align your special imaging accordingly. Now, what happens if you've got an X-ray that is reportedly normal, but you have pain and tenderness, as we've already demonstrated by our clinical findings? Well, one option is to put the patient in a thumb spiker splint and then re-X-ray in 10 days or so, and then reevaluate because the fracture may now become apparent. Another option is to go immediately to special imaging. And which one should you choose, an MR or a CT? Well, first of all, CT has the disadvantage of radiation exposure, which MRI does not. But if you look at the sensitivity, MRI beats CT scanning, whereas the specificity is roughly about the same. So if you were to choose, if someone has a so-called occult fracture that's not apparent on an X-ray, and you want to know that day, then choose an MRI as opposed to a CT scan. And this is a patient that you can see, you think there might be a scaphoid fracture just right here. You're not sure. The corresponding MRI, this is fat-enhanced images, show then the area of potential concern. And then, of course, when you do the fat-suppressed images, you'll see the inflammation and the bleeding and so on. So that indicates then the scaphoid fracture. So if radiographs do not demonstrate a scaphoid fracture and the patient has the clinical signs, then probably the best is to go straight to an MRI if you need to know that day, because that not only is more sensitive and specific, but also will show you soft tissue injuries. It's interesting, up to 25% of scaphoid fractures are not visible on X-rays on initial radiographs. And we know that a delay in treatment, even as little as a month or 6 weeks, can greatly increase the non-union rate. And we've said these are very troublesome bones to heal. Non-operative treatment, if done in a timely manner, and if the fracture is not displaced, has a greater than 90% chance of success of healing. If the greater the vascularity is in the distal part of the scaphoid, so a distal pole scaphoid probably only needs about 6 weeks of casting, but you cast until you've got radiographic healing. As you go more proximally in the scaphoid, so you need to cast for longer, up to 3 months if it's in the mid portion of the scaphoid, and proximal pole scaphoid fractures generally need operative intervention. During that time, however, if you've got an elite player, they are now deconditioned, and then it would almost end that season's play once they come out of their cast and they get going. So there is a higher tendency then to operate even on non-displaced scaphoid fractures in elite performers. In non-athletes, avoiding surgery may actually be preferable, and splinting and casting is a valid alternative. So there's a controversy in treatment, especially if it comes to opening and performing fixation. If it's greater than 2 millimeters displacement, then we do operative intervention. The rate of non-union with operative surgery is slightly better. The recovery is quicker. However, there are substantially more complication rates with surgery, to that degree that in the United Kingdom, when you're on the national health system, they disallow operative fixation for non-displaced fractures of the scaphoid because of the higher potential risk. But certainly, that risk taken into account, patients get back to playing, get back to work sooner, and more effective bone healing. And in the long term, for those particular patients, open reduction is in fact then cost effective. We have a number of different approaches by surgery. Generally, we'll go volar through that prominence of the scaphoid, and the screw or the fixation is then applied distal to proximal, and the wrist is flexed, is extended, and so that opens up the fracture and reduces the fracture. You can also approach it dorsally, and this had a high popularity because you're looking straight down the pole of the scaphoid, and you can do it through a small incision. It's preferred to do it through a small incision rather than percutaneously because of the potential risk of extensor tendon injuries. But then here you can see the screw placed in an antegrade fashion from proximal to distal, and from dorsal to volar. So small incisions, and also therefore less invasive. There have been techniques developed for doing percutaneous screw fixation using the volar approach. But as we've talked about, and this was a key article that has not been refuted, the complication rate of screw fixation in non-displaced fractures in some people's consideration is too high to warrant fixation other than in displaced fractures. Now getting patients back to sports, and we have to be aware of the cast that we put them in, and also this stress distribution when they land on the ground. And a patient who's got a short arm cast and they're forced into hyperextension, they might then now get fractures at the phalanges. So be very cautious when you're returning your patients back to sports, how you splint them and how you protect them. This might be a safer cast to wear, at least when they're playing, where the fingers are in a flexed position. And if you truly want to be indestructible, then you can put on a huge big cast, and certainly in football, providing these are padded, the rules will allow for that. But in other sports, they may not allow for that. But you want to be cautious not only about protecting the injured portion, but avoiding injury to parts distal to that, where you may have additional stresses when they land awkwardly. So this is what happens if you don't treat these in a timely fashion. So this is a patient who has a mid-waist scaphoid fracture that should heal even with casting and without necessarily fixation. But untreated, you can see this has gone on to a non-union. So that's not going to heal. We've now got sclerotic edges, and you've also got the early arthrosis forming with pointing of the radial styloid, and we've got a non-union. So now this becomes a whole lot more complicated. And you can see this is a young person who's just recently fused his epiphysis. So it's really important to get right on these right away and do repeat x-rays and be sure the healing process is going accordingly. Because a non-union now becomes a much bigger deal. You've, of course, got to use a screw fixation or pin fixation of some kind, doing a bone graft that may be necessary, tearing out that non-union site and putting in bone graft, and sometimes even a vascularized bone graft. So it becomes a whole lot more complicated issue to treat it when it goes to a non-union. And if you fail to treat a non-union, that patient will go on to full-blown arthritis in the wrist because the whole wrist will collapse around the fracture. So tied into scaphoid fractures are scapholunate ligament injuries. The scapholunate junction, there's a very strong interosseous ligament that joins those two bones together, and that is a key structure to maintaining the stability of the wrist. And a disruption of that ligament necessitates operative treatment. You may get partial tears or suspected tears, and these patients will have a clinical examination very similar to the scaphoid fractures. They'll be tender in the anatomic snuff box. They'll be tender over the scaphoid distal tuberosity, and so you may confound them for a scaphoid fracture. Here are the ligaments across the wrist. There is a dorsal scaphotriquetral ligament that is deep and joins those two bones. And there's a dorsal intercarpal ligament, which is sort of a two-layered protection and holding the bones together. But then there's also this very dense interosseous scapholunate ligament, and is particularly strong on its dorsal aspect and less strong in the membranous portion and volar portions. So when people get a partial tear, they may have pain in this area, but it's going to involve the less critical areas, the volar portion of the scaphoid lunate joint. And those you might detect then on an MRI, and the dilemma is what to do with those, and we'll get to that in a minute. So here we've got the dorsal ligaments, we've got the dorsal intercarpal ligament, and then beneath that you've got the scaphotriquetral ligament. And you may be able to assess carpal instability by the so-called Watson shift test. Not only is there tenderness at the scapholunate interval that we've talked about, but again, if we go back to our prominent tubercle, the dorsal pole of the scaphoid, the distal pole of the scaphoid, and you see as you go from ulnar to radial deviation, that flexes. So when I go into radial deviation, that tubercle becomes more prominent. When I go into ulnar deviation, it vanishes. So the scaphoid goes from flexion into extension as we go from radial to ulnar deviation. So it moves at 90 degrees to the direction that the wrist is moving. And if you then apply pressure to the distal pole of the scaphoid and force the wrist into radial deviation, generally speaking, that ligament is so strong that the scaphoid will flex, and you cannot resist that. However, if that scapholunate ligament is disrupted, then the scaphoid will be pushed over the back edge of the radius, and you'll feel a clunk as the wrist goes into radial deviation. And the reason the scaphoid has to move is because as you go into radial deviation, if you remember that inclination of the radius, the scaphoid gets pushed up against the radius. It's got nowhere to go, so it goes into flexion. However, that's governed then by the strong tension between the lunate and the scaphoid in that scapholunate ligament. So on X-ray, you may see a wide gap between the scaphoid and the lunate. You may have to induce that gap by that pencil gripping radiograph that I talked about, because it may be a dynamic change that you see only when you stress the wrist, or it may be static, as you see in this particular patient, where there's a wide gap between the scaphoid and the lunate. We've also said that the scaphoid goes into flexion, so you get the so-called ring sign, because you're now looking at the scaphoid end on, so you're looking down, so it's like you've got a tube, and so then you see this ring sign. And then the scaphoid, which is this bone here, seen laterally, pushes the lunate into dorsiflexion, so the lunate is pointing backwards. And then you may go to your MRI, and you can see here the lunate is facing backwards, and we've got a wide gap here. And the MRIs are so sophisticated that on the coronal and axial views, you can actually see those dorsal and volar components of the scapholunate ligament. There is such a thing as real-time MRI where you can actually open that gap and so on. That's not commonly available, and you can see the dynamic changes that are occurring. So treatment depends on the type of injury. If it's already gone into a static deformity, or whether it's dynamic, or if it's a partial injury. And I said the partial injuries will really only be alerted to because they've got persistent pain, and we'll get an MRI, and it will show you that that volar and intermembranous portion of the scaphoid ligament is injured, but not the entire scapholunate ligament. And there you might do therapy to do wrist raises to enhance the stabilizers of the wrist, or you might do an arthroscopic debridement of the ligament edges, or something that's gaining popularity. You can do electrothermal ligament shrinkage through the scope. So even though you may not have the overt total disruption, as we've talked about, the partial injury can be sometimes very difficult to diagnose. They've got persistent pain, X-rays are all normal, and you're going to have to then resort to your MRI and your experts to identify a partial tear of the scapholunate ligament. And sometimes we'll even do pinning. But because these ligaments are very hard to get to heal, they need to be casted, and probably not taking full stress for at least 3 months, and probably not full strength for 6 months. So even a partial injury can put an elite athlete out of a season or half of a season. If you get into total disruptions, and I'm not going to bore you with the variety of different reconstructions, but it becomes a whole lot more complex because we use tendon and ligaments to repair the scapholunate disruption. But it's, again, like scaphoid fractures, important to detect it early before it goes on to the full-blown disruptive pattern where you've got that so-called Terry Thomas sign, and the scaphoid and the lunate is sitting wide apart, and the scaphoid has gone into a flexed attitude, because then we have to do something much more drastic. So let's go on to the thumb, ulnar collateral ligament injuries. People sometimes call it gamekeeper's thumb, but gamekeeper's thumb really applies to the chronic injury from repetitive injury, whereas the skier's thumb is the acute injury. And so you land with your thumb stretched out, and the ulnar collateral ligament is torn on the inner aspect of the thumb. Here it's important to define whether you've got a partial or a complete tear, and there are two components to the ulnar collateral ligament. This is the proper collateral ligament, and then the one that goes to the volar plate is called the accessory collateral ligament. So when you're testing for stability of the joint, you test it in both neutral, in extension, and you test it at 30 degrees of flexion. Because if you are unstable at 30 degrees of flexion, then the proper ligament is gone. And if you are unstable in full extension, then the accessory ligament is torn. And if you're unstable in all positions, then both ligaments are torn. So it's important to test for stability and to test the opposite side, because there's a lot of variation in normal laxity of that MP joint of the thumb. So here you can see someone's got a clear instability, and that is a very disabling. You just can't pinch, you can't grasp, because the thumb just collapses under the weight of pinching. And if you've got a deviation of 30 degrees or more, or greater than 15 degrees compared with the opposite side, then you've got a total disruption of the ulnar collateral ligament. That may be demonstrated on your MRI scanning, where you can then see that the ligament is disrupted. The ligament, interestingly, nearly always tears off at its distal attachment to the base of the proximal phalanx. And here you can see a patient of mine with clear instability. You can see sort of a V-shaped here. So the joint is hinging open instead of a ball and socket rotation. And so clear hinging, and this is unstable. And this patient would have a total tear of the ulnar collateral ligament of the thumb. So people get hung up on what a Stenner lesion is, and Stenner described this in 1962 in this publication. And the extensor hood comes up from the side and holds the tendon centrally. And as I've said, the ulnar collateral ligament tears off distally. And so when the thumb is pushed into radial deviation, the torn ligament pops out from underneath the extensor hood. Now, when you go back into neutral position, it's caught outside and it can't reattach. And that used to be an absolute indication for doing surgery. Most people consider a total tear, whether there's a Stenner lesion or not, to do a repair of the ligament. And again, diagnosing this early and doing an early repair is important because you can use the native structures. If it's a chronic problem or a misdiagnosis, then you may have to use additional tissues to reconstruct that ligament. So this is a patient with obvious instability, and this is a so-called Stenner lesion. This is the distal end of that ligament that with a piece of bone attached to it, and it's escaped from under the extensor mechanism. And if you've got partial ruptures, usually they don't need surgery. They need to be immobilized continuously for at least 4 weeks, and then we'll continue an additional 2 weeks of immobilization, but they can now come out of it so that they can start doing thumb flexion and extension so that they don't lose that motion, but no side-to-side movement for 6 weeks. And again, ligaments are very difficult to get to heal. Bones sometimes heal better than ligaments do. And strenuous activity may have to be restricted for as much as 3 months, even with a partial rupture. Again, we can help the athletes out, and they may be able to play in a playing splint, which just doesn't go across the wrist. It just holds the thumb. It allows wrist motion and holds the thumb and gives you terminal thumb motion and finger motion. So they can, depending on the regulations of the sport, have a playing splint that will still protect them. We can do a direct repair, sometimes augmented with synthetic materials. And as I've said, if you've got a chronic problem and you don't have native tissues, we have to use then tendon grafts, for example, through bone tunnels to try and secure and recreate that ligament. So return to sports for a total repair. Anyone needs to be splinted for 6 weeks, then progressively weaning off the splint. But again, full contact activity waiting for at least 3 months. There are certain synthetics that we call the internal brace. It's a marketed, and that can augment the tendon that you would normally use, and you might be able to shorten up that return to play and return to strenuous activities, but it's still going to be at least 2 months before they're at full activities with the thumb unprotected. So lastly, we're going to get to epicondylitis, and we're going to talk specifically about lateral epicondylitis, tennis elbow. And it's much more common than medial epicondylitis, which is colloquially known as golfer's elbow. And it's a tear in the common extensor mechanism, the ECRB. And there are microscopic tears right at the junction where the muscle attaches to bone, the so-called Sharpie's fibers, if you people remember going back to your microanatomy and molecular biology. It can be as bad as a gross rupture, but it can also be a micro tear. The micro tears are still very painful and tender. There's tenderness directly over the affected epicondyle. And then because it's the extensor of the forearm, extensors of the wrist, if you take the wrist into flexion and you extend the elbow, you're going to really be stretching those muscles out, and that will elicit pain. Likewise, active extension of that wrist against resistance is going to cause pain. So is it a tendinitis or is it a tendinopathy? Well, we don't see inflammatory cells, so by definition, we now call all of these a tendinopathy. But we don't even know how to spell it. Is it a tendinitis with an O or tendinitis with an I? So it's just to show how confused we are over all of this. And in fact, taking you another leap forward, it's neither tendinitis nor tendinopathy. It's called an enthesopathy. So in other words, it's the origin of the muscle, the enthesis, where it takes origin from the bone, and it's attached to the bone, and that's where the tear occurs. So if you've got an origin tear of the muscle, and these may be micro tears even here, it's called an enthesopathy. And there's often a little bursa, and you may have a ganglion cyst associated deep to that attachment, and then you imagine the muscle goes on to the wrist off to the left. So here we have the common extensor origin, and all the extensors arise from the lateral epicondyle and then go to extend the wrist and the thumb and the fingers. So that then explains your clinical examination findings that we've already alluded to. The tenderness is maximum over the lateral epicondyle, and sometimes you'll see a little raised spur of bone where you get a periosteal reaction, but that's pretty uncommon to see that. Unlike some of the other conditions we've talked about where surgery is important, particularly getting in early, here non-operative treatment holds sway. Most will resolve, but it takes months. You may have to modify activity, such as changing a racket grip size or the weight of the racket. Immobilization with the so-called counterforce band, and we'll show that in a minute. Physiotherapy with stretches and then progressive strengthening, ultrasound and heat modalities, anti-inflammatory medications. There's a questionable use of injectable steroids, and sometimes this is overdone and it leads to complications. But there are some studies that show that steroid injections really don't help this condition. But if you are going to inject with steroids, use a water-soluble steroid. Do not use a fat-soluble steroid because it's going to hang around and be in the tissues for a long time. And so therefore it's going to increase your complications. So use a water-soluble steroid such as dexamethasone or celestone, and not a fat-soluble steroid. And these are some of the complications you can get of vitiligo, fat atrophy, and dermal thinning, which we don't want to see. You can see how much fat atrophy has occurred here. You can almost see the skeletal structures, the skeletal architecture, covered by a thin sheet of skin after all their steroid injections. This is the counterforce brace, which goes around the muscle bellies distal to the lateral epicondyle, and all that does is take the stress off the tearing point, the anchor point of the bone to the bone, which is at the lateral epicondyle. And the patients can adjust this Velcro according to how comfortable they are, and they can wear this under their regular clothes, and it's pretty unobtrusive and it's very helpful. And then if you go to the Orthopedic Academy website, they'll take you through the exercises that are done, and you can see with the elbow extended and the wrist flexed and extended, and how many repetitions you do, and how you then go from one stage of recovery to the next stage to the next stage over a several week time interval. And then occasionally we'll do operative treatment just because it's not getting better, or they've got very significant tear. And we've got two choices. One is doing arthroscopic debridement of the ECRB from within the joint versus an open surgery. So that terminates what we've had to do. I was also asked to do a case discussion, which kind of is nice because it excites your interest. And here's a patient who's a 17-year-old. He's an elite high school baseball player, slides into second base and hits the plate with an extended wrist. He immediately has a painful wrist on the radial side. What do you do as the coach? What do you do as perhaps the team doctor? Well, we've already said baseball has fairly strict rules, and probably best take the player out of the game until you've got further information. And then are you going to strap the wrist or carry on playing? Or are you going to take him out of the game? And then you're going to do your x-ray, and lo and behold, the patient, the player did have local pain and tenderness, had the classic findings of a potential scaphoid fracture, but lo and behold, x-rays are negative. But all they did was the 3-view x-rays. So you need to ask for that fourth view, the scaphoid view, which is the ulnar deviated view of the scaphoid. And now if the x-rays are reported as normal, well, you do a scaphoid view. Would you, in this patient, do advanced imaging? And if you decide not to do advanced imaging, but the patient has the clinical signs, what sort of cast would you put on? And you certainly don't have to do above the elbow, but most people would put a thumb spiker short arm cast on, although there have been some studies that show you don't even need to immobilize the thumb. I would play it safe and do a thumb spiker cast, short arm. This is the ulnar deviated view, still not too helpful for us. So are we going to go on to advanced imaging? What are we going to choose? We've already said probably MRI, because we not only is more sensitive than the CT scan, but it'll also help us look at the soft tissues and perhaps a scapholunate ligament injury. And that's probably your best initial cast, leaving the IP joint of the thumb free, lots of room for the fingers to move, but the thumb and wrist immobilized while you're waiting for your final determination. X-ray 10 days later, now we see the fracture because we've got lucency in the fracture line. Now what are we going to do? It's a non-displaced fracture. I would probably, even in an elite high school athlete, I would probably err in favor of not operating, because this is a mid-waist fracture. In 6 to 10 weeks, it's going to be healed just with immobilization, but that immobilization needs to be absolute. Although some may choose to do an open reduction and internal fixation, and we've already showed that the open reduction can be done through relatively small incisions, which was done in this particular patient. So that really does end the talk, and I'm very happy to entertain any questions that you might have, and I hope that was beneficial for you.
If you found this content valuable to you, please consider joining SMA by visiting sma.org/membership or making a tax-deductible donation. Visit sma.org/give to support our mission. Thank you.